Well, welcome everyone. My name is Mary Rapps, and I'm the Executive Director of Generations Healthcare Initiatives and co-chair of the 2020 Bridge to Health Survey process. Along with my colleague and co-chair, Maggie Rothstein from the Aiken-Itasca-Koochiching Community Health Board, we welcome you to the Bridge to Health Survey Conference. We want to start by acknowledging that we are gathering virtually from institutions, organizations, and homes from all over the Arrowhead region, located on the traditional, ancestral, and contemporary lands of Indigenous people. We build on land cared for and called home by the Anishinaabe people and other Native peoples from time immemorial. This land holds great historical, spiritual, and personal significance for its original stewards. We would like to honor the Anishinaabe people for their continued stewardship of the land and recognize the sovereignty of the Native nations from this territory. The Leech Lake Band of Ojibwe, Mille Lacs Band of Ojibwe, the Fond du Lac Band of Lake Superior Chippewa, Bois Forte Band of Chippewa, and the Grand Portage Chippewa, Miigwech. We are excited to see so many people with us today to learn about the health status of the region's population, and more importantly, to inspire action to create healthier communities throughout the Northland. I'm going to start by saying a few words about the Bridge to Health Survey process and thank the many organizations and people who have made today possible. This is the 6th time the survey has been conducted in our region. It began in 1995 and has been conducted every 5 years since that time. The main purpose of the survey is to provide reliable local data on the health status of residents in our region. There are national and state surveys that collect information on health. However, in most cases, the sample size is too small to allow for analysis on the county or community level, especially in a largely rural region. The Bridge to Health survey fills a gap in providing local data specific to our region. Also, we have the ability to customize the survey to collect information on what the region feels is most important. The Bridge to Health survey continues to be valued in this region, and it has been used in many ways. Public health and nonprofit hospitals for their community health needs assessments. Many organizations use it for planning and evaluation. Data is used for advocacy and policy and systems changes, and it has been used in hundreds of grant applications to leverage funding for health projects throughout the region. One aspect of the Bridge to Health survey that many of us appreciate and really enjoy is that it has always been a collaborative effort. This year, 64 organizations signed on as survey sponsors. The organizations represent public health, hospitals, clinics, community organizations, foundations, health plans, government agencies, and higher education. Over 42 representatives from these organizations have been involved with either serving on the steering committee, communications team, or data team. If we were all together live, we'd have these dedicated individuals stand up to be acknowledged for their contributions. And you would clearly see the depth of collaboration on this project. Of course, this survey would not be possible without funding. It has been a collaboratively funded effort. Maggie and I are going to take a moment to acknowledge our generous funders.
A big thank you to Generations Healthcare Initiatives as our presenting sponsor and for making the survey possible.
Our platinum sponsors were Essentia Health, St. Luke's, and St. Luke's Foundation.
At gold, Fairview Health Services, St. Louis County Public Health and Human Services, and UCare.
Our silver sponsors were Itasca, Aiken-Itasca-Couchiching Community Health Board, Blandin Foundation, Health Partners, Medica Foundation, and the Victory Fund.
At the bronze level, we're Carleton County Public Health and Human Services, Community Memorial Hospital in Cloquet, Cook County Public Health and Human Services, Fairview Range Medical Center, Grand Itasca Clinic and Hospital, Itasca County Health and Human Services, Lake County Health and Human Services, Lake Superior Community Health Center, Miller Dwan Foundation, Scenic Rivers Health Services, and Wilderness Health.
And our contributor level sponsors were Aiken County Health and Human Services and ARC Northland. Thank you, all of our financial sponsors. It goes without saying that this past year has been like no other. When we began planning the 2020 Bridge to Health survey, we had no idea what was in store for us. We held our kickoff meeting 7 weeks prior to the declaration of the COVID-19 pandemic. We had a handful of data team meetings before everything went virtual, and here we are gathered virtually for our conference. Everything changed so quickly: work priorities, work settings, family obligations, and personal challenges faced many. And our committed partners in this process rose to the occasion. Thank you to all of our collaborators for helping make the 2020 Bridge to Health survey a success. And thank you all for attending today's conference. Now Maggie will give you a preview for what is planned for today's conference. Maggie?
I have the privilege to introduce our esteemed presenters and to kick off the afternoon. I will start by sharing about the logistics of the event. We've got a tremendous amount of information to share. The presentation today will introduce the topics covered in the 2020 Bridge to Health survey and provide a high-level overview of the regional data findings. Our hope is that this will whet your appetite and you will take a deeper dive into the geographic areas and topics of interest. Following the regional data presentation by Ann Kinney and Mike Finch, Sonia Chose, Information Manager at Generations, will provide details on how to access the data and tools for data visualization. We have enabled Q&A, so we encourage you to put any questions that come up in the Q&A feature of Zoom. We will be monitoring the questions throughout the presentation, and we'll have 3 pauses to respond. If you have a question that doesn't get answered during the session, we will follow up by posting a Q&A document on the Bridge to Health survey website. And now, it is my honor to introduce our survey consultants and conference presenters. Both of these amazing research scientists have played an instrumental role in every single Bridge to Health survey since the beginning in 1995. Such an impressive record, and we are so grateful for their contributions to all 6 regional Bridge to Health surveys. First, Ann Kinney. Dr. Ann Kinney has been a senior research scientist with the Center for Health Statistics at the Minnesota Department of Health for the last 27 years. Ann serves as a resource to local public health departments and the Minnesota Department of Health for survey research and data needs, and helps oversee the planning, administration, and results dissemination of the Minnesota Student Survey. She is passionate about using data and to craft impactful strategies and stories. The second half of our research consultant team, Dr. Michael Finch, is principal of Finch and King and adjunct associate professor at the University of Minnesota Carlson School of Management. Mike is well known for his work studying the cost, quality, and financing of healthcare in public and private markets, and in long-term and integrative care. He has co-authored 3 books and over 200 peer-reviewed articles. How did we land such a dream team? We are fortunate. So without further delay, I'm excited to hand over the virtual stage to Ann Kinney and Mike Finch.
Good afternoon, everyone. This is Ann Kinney speaking. I'm hoping that you can see the slides. One moment. There we go. Can I get a thumbs up from somebody on the team? Thank you very much. Well, it is so nice to be with you. I echo Mary's comments about not being together virtually. I really wish I could see all your faces. This is always one of my favorite conferences, but it's great to be with you today. I've had the pleasure and privilege of being involved in all of the Bridge to Health projects, as Maggie said. It's always been one of my favorites. It was one of the first projects that I worked on when I started my career at the health department, so it has a special place in my heart. Mary gave you an overview of the project, so we're going to just launch into the methodology of the survey and some of the findings. And Mike and I are going to tag team on this section of the presentation. So first off, the Bridge to Health survey was conducted by mail in the late summer and fall of 2020. Our survey vendor was Wilder Research, and they were also the vendor for this project back in 2015. The field period was August 28th through October 23rd. To collect the data, we used the modified Dillman approach, and Dillman is for Don Dillman, who is widely regarded as the foremost expert in the survey research field regarding the methodology of mail surveys. And the approach works like this. To all of our households that we draw in our random sample, we send out initially a survey packet, which contains the survey instrument, a postage paid return envelope, a cover letter that describes the project and the sponsors and has a few instructions for the respondents, and a $2 incentive. Now, not always all surveys use incentives, but the Bridge to Health has found it helpful. 2 weeks after the first mailing, a postcard was mailed to everyone in the sample. The postcard has two functions. It acts as a thank you to those who have already returned the survey. And then it acts as a reminder for those who haven't done it yet to please do it as soon as they can. 10 days after the postcard is mailed, a second survey goes out, a survey packet that contains a slightly different cover letter, the survey instrument, and a postage paid return envelope, but not an incentive this time. The cover letter instructs that the adult who most recently had a birthday should be the one to fill out the survey. Thus, we only receive a survey back from one adult per sampled household. Our sample of households is drawn from the U.S. Postal Service's file of households that are eligible to receive mail. This resource is known as the delivery sequence file. It has become available to survey researchers in the last 15 to 20 years, and it's been a bit of a game changer. It is now the gold standard in this sample source for mail surveys. There's really no other source anymore. To design the sample, we divided the region into 12 strata, and we also call those sampling areas, which are based on geography. So the small insert to the left shows the entire geographic area with the states as well. But the blow up shows the 9 of the strata, 8 of the counties in their entirety, and northern St. Louis County without the city of Duluth. So that's the first 9 strata. The last 3 strata make up the city of Duluth, with Lincoln Park and the Hillside neighborhood, each being its own sampling area. So they're oversampled in this study. And you can see the map, actually both maps show those two oversampled areas. The final sampling area is the rest of Duluth. You can see the outline of Duluth as a whole to the left. And so the areas that are not Lincoln Park or Hillside make up the rest of the final sampling unit. This design means that we can calculate results for Lincoln Park and Hillside separately. We can combine these 3 areas in order to calculate results for the city of Duluth as a whole. And finally, we can combine Duluth and the rest of St. Louis County to calculate results for the county as a whole. At the end of the data collection period, every one of the sampling areas had achieved at least 400 completed surveys from area residents. And as you can see on the slide, some got quite a bit more than that. The range was 417 to 736 completed surveys in Cook County. We then combined all the data together into a single regional geography and the total sample size there was 7,590. The precision or the margin of error of the survey estimates at the regional level is at most plus or minus 2.6 percentage points. When it comes down to results at the county or oversampled community area, they'll be a little bit larger, those margins of error. The data need to be statistically weighted during analysis because the sample design is a complex one and because of differences in response to the survey by different demographic groups. So there are two different components of weighting. In the first component, we take account of the sample design by adjusting for the probability of selection. And by that, we mean the number of adults in the household, which is not all the same between households, and the population size of the geographic area, since, of course, different numbers of people live in each of our 12 geographic areas. In the second component of weighting, we further adjust the data by the age, sex, and education distributions of adults within each of the 12 geographies. Now, I want to do a brief review. As you know, the Bridge to Health survey has been going on since 1995, and over time it has seen a few methodological changes, but probably the biggest set of changes occurred last time in 2015. And so just to review, the changes that we made is we changed from the telephone collection mode to the mail mode of data collection. We added education level to the weighting adjustment. And because we added education in addition to age and sex, we needed to change our method of doing this adjustment from something called post-stratification to something called raking. If anyone wants me to talk more about that, I will do so if there's time. We did not make any additional methodological changes in 2020, but we continued the changes that were made in 2015. And so the 2015 became the new baseline to which we now can compare the 2020 results. In 2020, our response rate was 29.9% at the region level, comparing to 2015 when it was 28.6%. I want to talk a little bit more about the response rates. First, to show you the response rates for the 12 geographies. So you can see that there is variation in the response rate by the sampling strata, ranging from 20% down in the hillside area up to 37.2% in Cook County. All of the counties achieved over 25% in their response rate, and the two oversampled areas of Duluth were 20% and 22%. I want to show you a little bit about how Bridge compares to some other survey efforts. As many of you know, I am the advisor to all local agencies in Minnesota for this kind of survey work. Of course, Bridge to Health is the gold standard. But I did want to show you in the most recent surveys, these are since 2019, these are county level response rates at, since 2019. Bridge to Health is right in the middle. The regional level response rate is right in the middle. I'll remark on the outlier on the far right side of, of the slide, and that was a survey that was fielded literally when the stay-at-home order began. I think it went out into the field. It was mailed right when the stay-at-home order began last year, and I am convinced that there is a relationship there. But one thing to note is that response rates to survey did not fall during the pandemic. On the contrary, many were a little bit higher than we expect these days. And a final comparison here, when we look just at response rates for multi-level project level survey projects, so these are like the regional level for these other projects, we see that Bridge to Health compares very favorably to all of the rest of them. All in all, the Bridge to Health data team was very pleased with the data collection process and the survey data that were received from the residents of the area. And we were very happy with Wilder as our vendor again. Thought they did a wonderful job. So now I'm going to talk a little bit about who responded to this survey, some demographic characteristics of the regional sample. Now, these are weighted results, so they reflect the adjustments that we made by sex, age, and education, as well as the sample design. So when we look at that, naturally we see that the sample is just about half and half male and female. Looking at our poverty measure, we see that about a third of our adult respondents live at or below 200% of poverty. For this measure, we take the respondents' income and we adjust it for their family size, which we also collect on the survey. And then we calibrate it to the 2020 federal poverty level. So 200% of FPL is a relevant indicator and really useful one for us because programs like MFIP, WIC, food support, in Minnesota at least, all use 200% of poverty or less as the eligibility cutoff for these programs. So it's a helpful benchmark. Moving on, the sample is overwhelmingly white, 96.4, and 13% reported to us that they are military veterans. Looking at our distribution by age and sex, we do see that 18 to 34 is the largest age group. Do note that this group spans 17 years, while most of the other groups span 10 years. And they're pretty even between males and females until you get to the oldest ages. For level of education of our respondents, we see here that nearly 2/3 of them have been educated beyond high school level. So in an earlier slide, I showed you that in the region as a whole, about a third, 33% of adults live at 200% of the federal poverty level or less. So here we see when we look at this by age group, there really isn't much variation by age in this income measure, again, until we get to the oldest ages, 75 plus, when we have more of our respondents who are living at that lower level of income. Finally, here's employment status. Over a third of the respondents reported that they are retired. And it's not on the chart, but it turns out that just about 50% are employed full-time, part-time, self-employed, or some combination of those categories. Respondents could choose more than one of these statuses. So they certainly don't add to 100, and it isn't on the chart. You can't just add the bars together to get 50%. Now, we have a lot of great stuff to show you, but we're not going to have time today to show the results for every question on the survey. And we're just going to touch on each of these major topics. And honestly, these aren't even all of the topics that are on the survey. So we have, I'm going to continue talking about health status and prevalence of chronic conditions. Then Mike's going to come on in and talk about mental health status and utilization of and access to healthcare. I'll come back to talk about weight, physical activity, healthy eating, tobacco, and alcohol use. And then Mike will finish it off for us for questions that are largely new to the survey in 2020. And as Maggie said, we are going to have a couple of places where we'll stop and address your questions. Please be putting those in the Q&A, and we'll have Sarah moderate those during those Q&A sessions. So our first segment is about health status and the prevalence of chronic conditions. So here's the first question on the survey. In general, would you say that your health is excellent, very good, good, fair, or poor? This is a very common question for these sorts of surveys, and I believe it has been on the Bridge to Health in one form or another ever since the beginning. What we see here is that nearly 44% of adults rate their health as excellent or very good. We see that by looking at the blue and the red pie pieces. And that is terrific. However, we do see a change in this measure from 2015. And just to note, when you see the kind of faded looking colors, that's going to be the 2015 results compared to the bolder colors, which are 2020. That'll be throughout the presentation. So now comparing to 2015, look at the decrease in the ratings of excellent health between 2015 and 2020. So it goes from 14.5 down to 9.4 in 2020. And at the same time, we see the ratings of fair or poor health rise from 12.4 to 18.8. Other categories, just about the same. So to put this in context a little bit, I want to show you a figure from the data book, which I know you haven't had a chance to really go through in depth. This is figure 1.2, and it shows just those who rate their health as fair or poor by survey year in the Bridge to Health data. And if you're looking at that blue bar, or excuse me, that blue line, you can see that the increase in ratings of fair or poor health is not something that was trending in this region. So remember, we have a methodology change. That's the dotted line here. So we're not going to directly compare between 2010 and 2015, but that doesn't prevent us from looking at a trend over time. And we'll show you this several times throughout the presentation. So we see this measure was actually very flat or even trending downward a little bit until we get to this large increase in ratings of fair or poor health. So where in the population is this change taking place? So looking again just at those who indicated fair or poor health, we can see that adults in all age groups were more likely to rate their health this way in 2020 than in 2015. But the biggest change occurred among those youngest adults. Look at the size of that change. That is a 425% increase, a fourfold increase. So what if we break it down by income though? So now we're looking at all of the response categories for this question. And we see that for both those and above and those at or below 200% of poverty, there was more than a 50% increase in ratings of health as fair or poor between 2015 and 2020. So for the lower income, it went from 20% to 31%. For the higher income, it went from 8 to 13%. That's for both of those age groups. That's more than a 50% increase. So this increase in rating one's health as fair or poor happened at both income levels. If we turn our attention to the excellent rating, again, we see that big drop that we first saw in the two pie charts. And we again see it at both income levels. Here it's doesn't look like much, but that's still a 26% drop here for the lower income folks from 7 to 5. But looking at the higher income, that's a 39% drop between this 19% and 12%. So again, it was happening at both income levels, but it was even more pronounced for those at higher income. Let's move on to chronic health conditions. Remember, we only have a limited amount of time to talk about any one question in this presentation today. For chronic conditions, we asked respondents to tell us if a doctor, nurse, or other health professional had ever told them that they had any of this list of health conditions. And the list includes conditions that are commonly asked on health surveys like this, like high blood pressure, diabetes, heart conditions, asthma, but also some that are at least somewhat unique to Bridge to Health, like allergies, headaches, or kidney problems. And I'm not going to go through each condition, but I will report to you that the order in which the conditions appear, so high blood pressure being one of the top, and stroke being one of the least common, the order of conditions was really similar to what we saw in 2015. However, nearly all conditions showed an increase in reported prevalence from 2015 to 2020. So really some interesting things there. On the other hand, going back to our trend chart, again, this is a figure from the overall report that you now will have access to. We see, unlike the question we just looked at about how overall ratings of health, we do see that a lot of these health conditions were already trending up in this region. We see hypertension was trending up, diabetes was trending up, cancer, high cholesterol, kidney disease. So the increase in chronic condition prevalence between 2015 and 2020 is not so much of a story or a surprise as the overall health status question that we just looked at, which really was kind of a surprise in results. I'm now going to turn it over to Mike Finch to talk about mental health status. Take it away, Mike.
Okay, and hopefully my mic is working.
Your mic is great, Mike.
Thank you. So we looked at chronic diseases, but let's now look at mental health status. And this is a response to the question of, has a health professional ever told you that you have depression, anxiety, or panic, PTSD, or some other mental health condition? And you can see these results, and they're fairly, don't forget, people can answer to more than one of these. You can have depression and anxiety at the same time, but clearly 25% or so of the folks in the area either have depression and or anxiety, pretty high levels here. So if we can look at the next slide, the interesting thing here is we wanted to look at, again, 215 and 220. We see the same sort of thing. We see that the trend is increasing. It's a small increase, and whether it's statistically significant or not, it probably is just marginally significant. But again, something to look for. PSTD we didn't have in the previous survey, so you don't see anything there, but these look fairly similar. But let's look one more time at the next slide here. And again, here's what was the prevalence of mental health conditions by survey year from the past. And we can see again, slight increases every year. but they're leading to larger and larger increases over time. If you start looking at the earlier times, the current times, even with this methodological change, you see this trend is increasing across both anxiety and depression and other mental health conditions. Next slide, please. And so here we broke it down again to look at males and females. A lot of times we look at these, what we call, the top line numbers, what happens to the population. It's much more interesting to break it down and look at what's happening to individual groups of people within the population. And you can see here across all ages, the relationship between prevalence of depression is much higher in females than it is for males across the board. Next slide, please. Anxiety has the same exact relationship. And this is fairly common. We see this in the literature. This is not an abnormal result, but our numbers are getting higher. The discrepancies are getting a little higher also. Next slide. Here we look at PSTD for differences in males and females. And if you look at these results, they're fairly similar, except when you get up to the 65 and 74-year-old. Now, we don't want to make too big a deal about that or the 18 and 34-year-old because most of these are fairly similar. The differences look big, but don't forget our margin of error of this survey is a little over 2 points plus or minus. So we have to keep that in mind here. Next slide, please. This is a big one. Okay. This is depression by poverty status. And as Ann said, we use 200% of the FPL, the federal poverty level, or less, because it's a number that's often used by federal and state government to allocate resources to folks. And you can see that this is, double the rate of the people over 200% of poverty. This is a big difference. Next slide. And here's the same thing with anxiety, not quite as large a difference, but same trend. And again, still a very large difference here. A lot of disparities in terms of income for both depression and anxiety. Next slide. PTSD is the same thing. Remember, we didn't see much change in PTSD over time, except for the very young and the very old. But here we see a huge difference. This is a threefold difference between those below 200% of the poverty level and those above 200% of the poverty level. So next slide. We'll look a little closer at some of these things. We also asked folks for how many days during the past 30 days was your mental health not good? And the blue bars on the right give us a nice distribution. Basically, it says half the people had no days where their mental health wasn't good. But if we look over on the other side there at the red numbers, we see that 84% of the people say, over this 2-week period, fine, but 15% had more than 14 days in a 30-day period. More than half the time, they were feeling frequent mental distress. Okay, their mental health wasn't good. Again, this is a big number, and it's one that's worth considering. Next slide, please. Now, a lot of these are tied to other things, other social components. We're going to talk later on about resources people have available to them. We're going to talk about their social support systems and things like that. All these are related, and that's why you're going to see some of these in our mental health section. So how often do you get social and emotional support you need? Usually and always 70%. Fairly good number. And if you add, sometimes it gets very high. Can we look at the next slide? How often do you feel lonely or isolated from those around you? Never, rarely, again, about 65%. Sometimes adds another 23% to it. But again, you've got 10% of the people say, I often or always feel lonely or isolated. Can I see the next slide, please? This is a new question that we asked this year. A couple of these questions, well, quite a few of these questions were new questions. And the data team was really interested in a lot of these issues that might have been caused by COVID. We were very sensitive to it, but they're not just COVID related. We need to track these over time to see what the long-term impacts of them are. This was one that we added. And you don't see this in many surveys today. So it was a nice addition. I lead a purposeful and meaningful life. And if you look at that, we're looking at, 90% of the folks are saying yes. And you've got 10% saying no. Can you go on to the next slide? Do you sense a sense of belonging or connectedness with somebody outside of your family? 66% say yes. 20% aren't sure, which is an interesting answer in and of itself. And another 15% say no. So you can see there's this constant 10, 15%, 20% of the folks that experience some kind of emotional, mental health concerns, social support, lack of social support, isolation, not feeling like they belong. Now, I can't tell you from these slides if these are the same people, but that's something for someone to dig into this database and really look at, because it's going to be an important finding for you. If you can keep going to the next slide. And here's we used a fancy statistical technique to clump these responses together because there were a lot of different things people could say. And as you've just seen, so we said, look, if you responded to any of the following, I rarely or never had the social or emotional support I needed. I often or always felt lonely or isolated, and I disagreed strongly that I have a meaningful life. And I said no to a sense of belonging and connectedness. If you put any of those together, it's clearly a third of the population. And this is what I was saying. We need to dig into these numbers a little bit more and really look at them. This is a third of the population that said yes to at least one of those. And many of these people said yes to more than one of these. Next slide, please. And here we look at the social connectedness by perceived isolation again. And we're looking at those who have none versus any, and we're looking at it by age. And if you look at the none, the numbers bounce a little bit, but don't forget we have standard errors around these. Fairly consistent. The 18 to 34 are a little lower. And if you look at the other side, though, that say they have some score there, they have one of these at least. You see that 18 to 34-year-old, that 39, 40% basically is 10% higher than anything else there. Again, an important thing to start looking at as you start thinking about your projects, thinking about planning, think about the issues you want to tackle in the Northland. Next slide, please. And this looks at social disconnectedness, the same question that the combination we put together, but looks at it by gender. And here again, you see that more women say no to this than men. Okay. And this is an interesting thing because we saw depression and anxiety, and we usually see this in mental health issues. Women report more of these things than men do. It's strange when you see men reporting more of these sorts of things because we have this idea that they, from survey research, that they're less likely to say yes to some of these things. And so this is probably an undercount of the male population in here. But that difference is, almost a 50% difference in the response of those who feel that way. And here it is by poverty status. And again, if you look at poverty, we do have a 50% difference in terms of 50% higher for those in less than 200% of the federal poverty level. Next slide, please. Okay.
We are here at our first set of opportunities to ask questions. So Sarah, if you have any for us, we'd be happy to tackle them.
I do not see any questions in the Q&A right now.
All right.
So just want to remind our audience that go ahead and you can put them in the Q&A.
That's great. We'll just keep soldiering on here then. Mike,
we can, and I encourage you to ask questions. You can catch us afterwards, but it's easier to catch us now. Okay, let's go on to our next section. This is the utilization of and access to healthcare. Next slide, please. There we go. So how long has it been since you visited a doctor or other healthcare professional? Okay. Well, 83% did it in the last year. And don't forget, this was a COVID year. Is that a good thing or is that a bad thing? Well, let's look at the next slide. Okay. Here's a place that says, there's a usual place you go. And we said, yes, about 73%, 75% said the doctor's office. The one we track on here is the emergency room. That's been going down over time, but it's one we've tracked for a long time because we used to have a lot of people using the emergency room as their primary care. We're seeing a little bit more of the urgent care center these days. So next slide, please. Here's our type of health insurance that people have. Again, almost 70% have private insurance of some kind. 50% have private with no Medicare supplement. So a lot of those people in the private insurance are on Medicare, but they have a supplement. It's always interesting how people answer this question. We have to I shouldn't say complicated, a very long way to ask this question because people don't always realize that they have insurance or what kind of insurance they have. You've got about 35% on Medicare, another 12% on medical assistance. We would usually clump those two together. Other public things could include the VA and other resources like that. And those that are currently uninsured, 2.9%. Next slide, please. How long has it been since you last visited a dentist or a dental clinic for any reason? 62%. Saw some 63% in the last year. 11% said 5 or more years ago. Is this good or bad? We'll talk about that later. But here's part of it is that if you look at the 200% of federal poverty level and below, okay, you see that 42.9% of people saw a dentist last year. If those who are above 200%, it was 73%. If you look at the 5 years ago, for those above 200%, it was 7.5%. For those below, 19%. We've known for a long time that we have a huge disparity in access to dental care. Medicaid is a difficult payer for dentistry. It doesn't cover everything. The dentists are reluctant often to take Medicaid, folks. And when you're talking about people at 200% of the federal poverty level, many of them are on Medicaid. Next slide, please. So this is a new slide we added, and it basically says, you know, where would you seek help? And could you seek help at your primary care clinic instead of going to a psychiatrist office or a mental health clinic? What if it was offered in your primary care clinic? And we see that about almost, 70% of these people say they're much more likely or more likely to seek mental health care if it was offered in a primary care clinic. This is an important piece because people see their primary care physician more than they see other people. Getting into a specialist is harder. Making the decision to see a specialist is harder. Talking to your primary care physician is much easier because you oftentimes know them well, they know you. This is a nice finding for the folks who plan on how we get and where we get our services, especially on the mental health side. Next slide, please.
Thank you, Mike. I will return now to talk about weight status, physical activity, and healthy eating. These are some of the public health topics that we often assess on these sorts of surveys. These topics, along with tobacco use, continue to be the focus of the statewide health improvement partnership, which all local public health agencies take part in and is a large program of Minnesota Department of Health. The Bridge to Health survey measures respondents' height and weight. So we ask folks to tell us what their height and weight is, and then we calculate their body mass index and their answers. So we don't expect ordinary citizens to happen to know what their body mass index is. There has been a lot of discussion in recent years about BMI being not the best measure for measuring obesity, but it is the one that we can measure with relative accuracy on a survey because it's relatively easy for respondents to report to us. I invite you to look at the regional data book, chapter 4, for a little bit of more of a discussion on BMI as a measure. In 2020, what we see is that 29% of respondents are considered not overweight. And just to review, that means their body mass index is less than 25. 34% are considered overweight but not obese. That's having a body mass index of 25 or greater, but not more than 30. And then if your body mass index is 30 or more, you're considered obese. And in 2020, 37% of our regional respondents are considered obese. Now, when we compare this to 2015, we see that the kind of a third distribution that we saw has become a little bit more skewed, a little differently skewed, I should say. Obese has increased from 31% to 37%, and not overweight has decreased from 33% to 29% since 2015. So the obesity epidemic is still with us. There are lots of things to explore about who is and who isn't overweight or obese. And again, in the interest of time, we're just going to look here at those who are obese according to their BMI in 2020. And we can see it's less prevalent among the youngest and oldest adults. That's here on the left side in the blue bars. And it is more common among those living at less than 200% of poverty or less. I don't have a slide for this, but compared to 2015, obesity increased a little bit among those under age 65 for both males and females. Moving on to physical activity, we see that over 80% report having taken part in at least some leisure time physical activity during the past 30 days. The question asked, during the past 30 days, other than your regular job, did you participate in any physical activity? And then there were a number of examples given. And it's simply a yes or no question. Note the difference we see by poverty status, that those of lower income are less likely to report leisure time physical activity. Still, a vast majority of both groups have taken part in at least some physical activity. And these results are virtually the same as what we saw in 2015. So we just saw that over 80% of respondents report some activity in the past month, but let's get a little more specific. So we have a couple more questions about physical activity that ask about moderate and vigorous activity. So the blue bars represent the moderate activity, which, let me see if I have the question here. Yeah. Other than your regular job, on how many days do you get at least 30 minutes of moderate physical activity, which causes only light sweating and a small increase in breathing or heart rate? So what we see here, we see that most adults do at least some moderate activity, and we can tell that because only 12% report that they spend 0 days doing moderate activity. But just 34% meet the old CDC guideline of 30 minutes or more on 5 or more days of the week. And that is on this farthest right blue bar. If we look then at vigorous activity, which is the red bars, that question asked on how many days do you get at least 20 minutes of vigorous physical activity, which involves heavy sweating and a large increase in breathing and heart rate. So looking then at the vigorous activity bars, we see that about 33% meet the old CDC guidelines of 20 minutes or more on 3 or more days per week. Now we have to do a little math there. We have to add the 19.9 to the 12.7 to get to the 32.6. On the other hand, we do see that over a third report no days of vigorous activity. Again, these results are virtually unchanged from 2015. Moving on to healthy eating. Here we see the overall results for total servings of solid fruit, fruit juice, and vegetables consumed yesterday. We see here that fewer than a third of adults reported eating a total of 5 or more fruits and vegetables yesterday, while more than a third reported eating 3 to 4 servings. When we compare this to 2015, we see a change. We see more adults eating 3 or 4 servings and fewer adults eating 5 or more servings. So that's an increase of 7 percentage points for the 3 to 4 servings and a decrease of 6 percentage points for the 5 or more servings, Both of these differences are statistically significant, by the way. We do see a slight decrease in those having 0 fruits and vegetables, though. A new set of questions in 2020 asked about the consumption of various sugar-sweetened beverages in the past week. We assessed for regular soda, sports drinks such as Gatorade, juice drinks such as Snapple, energy drinks such as Red Bull. So the slide shows you that regular soda was by far the most commonly consumed of these things, with in the green bar there to the left, 15% consuming regular soda daily in the past week, and an additional 38% at least once in the past week, but not daily. Looking at those other types of beverages, they're much less commonly consumed, yet still about a quarter reported having sports or fruit drinks at least once in the past week. We asked a question like we did in 2015 about how often folks buy or get food from different food venues. We can see here supermarkets or large grocery stores are by far the most common places that adults go to get their food. That's the yellow and purple bars to the far left. Nearly 2/3 go there once a week or more. For the other venues, half or more, or sometimes vastly more, visit these places only once per month or even less often. And the patterns you see here were very similar to the ones we saw in 2015. Just a little preview, Mike will spend some more time talking about getting food from a food shelf or food pantry later on in the presentation. I'd like to turn now to tobacco and alcohol use. According to the 2020 Bridge to Health survey, the adult cigarette smoking rate in the region is 15.8%. I don't have it on the slide, but I can tell you that nearly half of those current smokers, that's 45.7%, had stopped smoking for at least one day in the past 12 months because they were trying to quit. Here's a piece of good news. Cigarette smoking dropped by 3 percentage points since 2015. That's a 16% drop between 2015 and 2020. I'll encourage you to go and look at figure 6.1 in the regional data book when you have a chance to look at that. There's a lot going on in that figure. That's why I'm not showing it here, but what you'll see is that the decrease in cigarette smoking continues the trend of decline that we've seen in the past Bridge to Health surveys, and honestly in all other longitudinal surveys of tobacco use. Cigarette smoking has been declining for 20 years. But we were interested in where in the population this decline is occurring. So we always see variation in cigarette smoking by socioeconomic measures like education and income. So here we see that the decline from 2015 is most among those with less than a high school education. That's a huge drop, 43%, or who have a vocational trade school degree or an associate degree, and that's a 36% drop in cigarette smoking here. And this is really an interesting finding to me because it does appear a lot of times when we look at tobacco data that those education groups are really kind of the hard ones to move the smoking rates among. They're always, usually higher than other types of groups. So it's exciting to see some change occurring in those groups. And when Mike and I looked at these results getting ready for this presentation, he said, well, what's happening? Are these people switching to e-cigarettes? So let's take a look. In the 2020 survey, we asked a long question about electronic cigarettes. Here it is. Have you ever used an electronic cigarette, vaping device, mod, Juul, or other electronic nicotine delivery device, even just one time in your entire life? We don't like changing the wording of questions that we want to trend over time. But in the case of e-cigarettes, the range of devices and options changed so quickly between 2015 and 2020 that we kind of had to in order to accurately capture what was going on in 2020. The question in 2015 was much simpler. Have you ever used an electronic cigarette or vaping device even one time in your life? So it's much simpler and shorter. So we see here that ever having used an electronic device, the rate was 16.3% in 2020. And that overall rate in 2015 was 17.2%, and we consider that no change there. That's not a statistical change. So now let's look at this by those same socioeconomic categories. Interestingly, we see the same dramatic drop in the ever use of e-cigarettes among that lowest educated group as we see with traditional cigarettes. So they weren't switching out necessarily to e-cigarettes. On the other hand, if you look closely, some of the other educational groups, such as those with vocational or associate degrees, those do show an increase since 2015. And we see here that the higher income folks also showed a little bit of an increase since 2015. So we really need to keep monitoring e-cigarettes. I have one more slide to show you on this. There's a lot of things going on in this slide, so bear with me here. What we're seeing is the rate of ever having used an e-cigarette by age here along the bottom, but then also broken out by male and female. So first, notice that the overall pattern is that younger adults are more likely to have ever had an e-cigarette than older adults. But then look at the differences with male and female. There's a huge jump in the youngest males, 18 to 34, in the percentage of those who have ever tried an e-cigarette between 2015 and 2020. That's a 50% increase. But on the other hand, we see a drop in use in every single other age group by sex, including the youngest females. So that's quite an interesting thing. We're going to need to delve into that a little bit more to try to make sense of some of these things. And it just again reinforces that we need to keep monitoring e-cigarette use. We certainly monitor it very closely for youth, but we need to keep monitoring it as well for adults. Here's a new question that we added in 2020. Among those who have ever tried an e-cigarette or other vaping device, we asked, were you a tobacco user at the time you first used an e-cigarette? We see that 3/4 of those e-cigarette users were already tobacco users at the time they tried it. But this means that 25% of those who had tried an e-cigarette were not already cigarette smokers or users of some other kind of tobacco. And again, Mike and I were talking about these. He says, who are these people? So we took a look, and you see in the box there, these folks who basically are their introduction to nicotine delivery is through e-cigarettes. They are more likely to be young than those who are already tobacco users. They're more educated, which means they had vocational tech or trade school diplomas or associate degrees or were college grads. And they were also of higher income, greater than 200% of poverty. So that's a group that we might want to do quite a bit more on of looking at to see what's going on with those folks. So the last topic I have to talk to you about is alcohol use. What we see here is that most adults, that's 2/3, had at least one drink of alcohol in the past 30 days. Heavy drinking was about 17.1% in the region. And again, that definition is an average of 1 drink per day or more for women, or an average of 2 drinks per day or more for men. Finally, the binge drinking rate was 30%. And again, that definition is 4 or more drinks on an occasion for women, 5 or more drinks on an occasion for men. Now, interestingly here, we see virtually no change from 2015. But what that means is in this region, alcohol use did not increase during the earlier part of the pandemic. Remember that the field period for this survey was August through October. So that's still the earlier part of the pandemic, the summer and fall. But we are not seeing, at least at that point, an increase in alcohol use. We again have a break here. So if there are any questions, we would be happy to entertain those. So do we have any this time?
We do. We have one from Nick, and just wondering, are there efforts to survey more diverse populations given the history of disparities in health outcomes?
Well, what I can say about that is I believe that there are some plans in the works to do some additional data collection among some of those populations. As you saw in the one of the earliest slides, the bridge to health population that responded to this survey is overwhelmingly white. So for most of our racial and ethnic groups, we did not receive enough respondents to confidently report results for them separately. So I know that last time in the Bridge to Health project, there were some additional data collection efforts that were made. I don't know if anyone wants to remark on those a little bit, or Mike, if you want to say anything else about this.
Yeah, I think that it's always hard because the area is quite white, but we oversampled a couple areas in Duluth, both in 2015 and 2020. So those of you who are interested, I'm sorry you're not going to be able to look at the whole area, but there's a couple of neighborhoods that I think could really use some of your insight and some of your attention. And I think we've got enough sample size in there to give you some ideas of what's going on and where you might be able to make some impacts.
Thank you. One more question. Is there an impact on underreporting on measures such as for depression or anxiety in relation to stigma or shame? And if so, is there data or rates that you estimate this would impact or influence response rates?
The answer is yes to the first one. And I don't know of any good estimates to figure out the social desirable, what we call social desirable responses. Sometimes we compare it to utilization patterns in an area, but not everybody's insured and not everybody we don't get full reports. So it's really hard to say what it is. We do know it's an undercount. When we do things like diary studies, where we ask people to document their feelings usually every day, we do get higher numbers.
Yeah, I agree. That's a very difficult thing to estimate. I'll point out, Mike talked about delay of care in one of the earlier slides. We also had a question about if folks delayed mental health care that they thought they needed. And of those that said they did, one of the most common reasons they reported is embarrassment or feeling afraid.
Yeah.
So it's certainly out there. Hopefully that helps.
Thank you. I think we can move on now. We have one more question that we'll ask a little later. Go ahead, Mary.
Oh, I think we can probably take that question now. It's an easy one. I think we're ready. Sonia has looked up the comparison of the uninsurance rate. Question came through about how did the 2020 rate compare to the 2015 rate? So Sonia, can you take that one, please?
I will, Mary. So yeah, the 2015, the currently uninsured was 3.9%. And in 2020, we reported 2.9%. So making progress in the right direction.
Thank you very much, Sonia.
Yes, I was looking for it and couldn't find it.
Anything else just now?
Nope.
All right. Mike, I think we're back to you with some of the really exciting new things that we have for you.
And we do have a number of new questions in here. I'll try to remember to tell you which ones they are as we move along. But these are the social determinants of health. And, and we were asked, the fun things. And we had a meeting with the press today about why we work on this study, what we like about it. I enjoy the fact that the community has so much input to it, but I really, really am amazed at how much you folks in the audience use this data and the ways in which you look at the data, the ways in which you take it apart and actually come up with good solutions. And, it's just so rewarding to see the data that we collect being used in these ways. And this social determinants one is one of the key things. We all know how important social determinants are, not just in health, but in all of our welfare. And we've got a number of questions this year that we put in, and you saw some of those earlier. So let's start looking and going back. We talked about people using food shelves and food pantries. And let's look at this. Here it is. How often did you use it? Never or less than one time per month? 90%. Okay, 10% use it once a month or more. But let's look at the next slide. Here again, we're dividing this up by the federal poverty level. Look at those differences. Look at those different. That's a tenfold difference in the response of who's using these facilities. And of course, people look at this and say, well, you know, COVID affected lower income people a lot. Was there a COVID effect for this year that was causing this huge difference here? Let's look at the next slide. And hopefully I have that in there. Do we have the,
It's right there, Mike.
whoops. Yes, this is the 215. Thank you.
Yep.
And yes, it went up. Okay. But it went up from 20% to 25%. Is that a big increase? That's a 25% increase. But it's not the whole increase. So that increase was not just a COVID effect and shouldn't be seen as a COVID effect. It really is a systemic issue that we need to deal with. And it's still around. Is it as bad as it was this year? Probably not going on long term, but it's still a big issue. Next slide. And here are the barriers to having adequate food for your household. Almost 80% say there are no barriers. Cost of food comes up as a good one. Pandemic comes up, you know, for 9.5% of the people. So pandemic did have an effect on having adequate food in the household this year, and people respond to that. Cost of food, we always see the cost of food come up here. Next slide, please. Here we did the same thing though. We divvied it up by the federal poverty level. And again, we look at the barriers, and 60% of those above 200% had barriers. Of course, we all had barriers this year. The grocery stores were empty. It was hard to get there. You couldn't get food that you needed. But it was 86% of the people below the 200% level who had no barriers here. Excuse me, who had 200% or less had 60% of people had no barriers. If we look at the cost of food, it's 7% at less than 200%. It's 15%. Basically, as we go down the line, these are good sized differences. When we get into the small percentages, they're big relative differences. They may not be statistically significant. There was a lot of people that are affected by them, and we should keep those in mind, even though they're fairly small. The only one that we see that was any different was lack of time to shop. So next slide. We wanted to look at housing this time, and there was the big push by the community to really ask some questions about housing more than we did in the past. We've always asked some things. And do you own or rent your home? We've asked this for a long time, and here it is by all adults in this area. Almost 80% of the people own their homes, 17% are renters, and 5% are either homeless or couch surfers. And you look at it by the age groups, it's sort of what you expect to see. It's ownership is going up, rentals going down, other services are going down over education. And when we look at the federal poverty level, you've got 50% of people below 200% who own their own home, and another 38% who are renting. But you also have a high percent that have some other arrangement for housing, whereas those are much, much smaller as both the rentals and the other arrangements for anybody above 200%. Remember, 200% of poverty level is not that high. I mean, we're not talking about people with a lot of disposable income. And so home ownership is large up here. Can we see the next slide, please? So this is a new question, and the folks were really interested in making sure the data team was really interested in making sure we asked these questions and got them on board, because there are tons of barriers out there to obtaining housing. So of the 6.4% who had any issues, half of them said it was the lack of affordable housing. They just couldn't find anything that they could afford. Initial rent and security deposit payments were another issue, along with poor credit or lack of rental history. You can imagine those overlap quite a bit. You can see the rest of it. Can we see the next slide? Here, we broke it up by owners and renters and people who have other arrangements. And you can see again, that lack of affordable housing. Does it affect the owners? Of course it does, but it really affects everybody else, as does poor credit, as does any kind of financial payment or, upfront deposits. Overall, those are all hard things. Could you not get a mortgage? Really popped up. But go ahead to the next slide. This is a fun slide here. We did the same statistical magic I talked to you about before. And we looked at the data, the computer looked at the data and put together people who responded in similar way. Similar across questions, they responded similarly. So if you answered one, you are more likely to answer a couple of the others too. And we broke it out again because I think this is a clearer picture rather than looking at all those individual items that we asked about of what's going on. Initial rent, security deposits, lack of affordable housing. These are basically all financial characteristics, and they tend to affect everybody, some more than others. And if you look at the people with another arrangement, it's a huge effect. We've got criminal records, previous rental history, history of unpaid utilities. You can see how those work here. And again, those are higher actually for the owners than they are for the renters. Other issues, lease requirements, difficulty finding a place near public transportation. I found that one particularly interesting. And those differences are really significant. Everybody thinks that they're close to, I shouldn't say they're statistically significant, they're close to being there. But that 4 to 7%, everybody seems to think that transportation is a big issue for people who rent or have other arrangements. It's also a big issue for people who are buying homes, own homes. It's transportation. It's not just transportation and housing, it's transportation in general is a key. A lot of people use public transportation or some other form of transportation, and these are problems for us in terms of finding adequate and affordable housing. Next slide. What are the things you experienced in trying to keep your housing in the past 12 months? And again, this was among those that had issues. They lost their income. COVID year, we expected to see a lot of that. Some of this, of course, happens every year, but this was a bad year. A lot of people did lose jobs and couldn't keep their housing. The cost of utility payments was big. They couldn't afford their rent or mortgage. You're going to see those go into lost income and things like that. We've got a whole other list of things here that we always see show up. Issues with landlords, change in family or household situation, issues with neighbors. Poor substandard housing conditions really goes along with trying to find affordable housing in general. The next slide, please. Here we broke it up again by owners, renters, and other arrangements. And you can see how lost income affected everyone. Cost of utility payments affected everyone. It really affected homeowners at the same time. Issues with landlords really didn't affect homeowners. Thank you. You always get odd, I'll tell you now, you're always going to get odd answers in the questions like this. You have to think about how people think about things, okay? You couldn't afford your rent or your mortgage, makes sense. Issues with my landlord, that should be, nobody who owns a house should have an issue, but they do. So when you look at this data, take those things into account as you're going through your data and putting together your plans for what you're going to look at and how you're going to move things ahead. Next slide, please. So here again, we put these things together and you look at the cost, basically cost of utilities, lost income, couldn't afford the rent or mortgage, changing your situation. Were these barriers to keeping your housing for 92% of the owners of the 7.2% who had a barrier? Almost all of them had an income problem. 60% of the renters who had a problem had an income problem. 44% of the people who had another living arrangement, it was the result of an income problem. So this was a big year, and a lot of this was probably COVID related. We really need to understand how much was COVID and how much looks like it's a systemic piece that trends through time. So you hate to wait another 5 years to find it out, but it's a place where people may start looking now to see, are things returning to normal or are they still bad? And for those people who lost it, it's going to take them a long time to return to normal in terms of their housing situation. So something to look at, and something to look at in the near term. Next slide, please. And this was a new question for us this time too, as you can well imagine, because everybody was internet bound one way or the other. Do you have access to the internet at your current address? 86% of the folks said yes. This is a big issue up here in the northern areas because we've got a lot of rural areas. We've got a lot of areas that don't have underground wires, that don't have direct service. They depend on other ways to get their internet. If we look at it across education, it's exactly what you'd like to see, well, what you expect to see, not what you'd like to see, what you expect to see in terms of increasing levels of education, have higher access. People who have more money have higher access, but those at 75, at under 200% of the poverty level, 75%, 3 out of every 4 still had access to the internet at the place where they live. We're not talking about going to the library or going to work or somewhere else. At the place where they live, 3 out of 4 had access. Owners, 90% had it. Again, though, 75% of renters had it, and 75% of folks who had other arrangements had it. A well-wired geography, basically. But let's look at some of the barriers that come up here. Can we see the next slide here? Here's the barriers. You know, 2/3 said no barriers, not a problem. The next biggest is 21% said have inadequate internet service. I live in Minneapolis, and I can tell you I've got Comcast, so I have inadequate internet service too. Equipment is too expensive. All these are smaller things are important, but the big things, if we look at the next slide, we start to look at how we break these things up. Inadequate or no service, the equipment is too expensive. That was 25%. I don't have the necessary skills, so 6%. Not enough devices is another 6%. Ann and I were looking at this and we thought, I wonder what's going on here. And I think if you look at the next slide, you'll get at least a first view of what might be going on here because we broke it up by age. My favorite part of this slide is the far right-hand side, which says, do you have the necessary skills to do this? And if you look at the youngest age groups, they all have it. And as the age goes up, we get more and more people who have skill issues in terms of using the internet. I can tell you when we do telehealth, we've run into this all the time. We think it's pretty simple. Just click an app, you're online, you can talk to a physician. Not so if you're a senior. It's much more difficult just to understand how the things work for a lot of people. If you switch back over to the far left and look at this again, inadequate or no internet services, the youngest group seems to have a slight deficit. Across the middle ages, it looks pretty good, and then it starts to go down over as we get to the older folks from 55 to through 75 and older. And not enough devices. The youngest groups are saying they don't have the right devices or enough devices, and that goes down over age too. Interesting findings, but I think as we talk about health and we talk about telehealth and the new healthcare that's going to come post-COVID, and we talk about connectedness, and the data team was really, really on top of this and asked a lot of good questions about what we need to know about internet connectivity, interconnect access to devices and skills. This is an important piece for us to really look at. I'm glad we really got this into this survey this time. This is the first time we've asked this. Next slide, please. Okay, so let's look at another effect of COVID, at least one that we posited during the whole period of COVID, was that we would forego healthcare. Let's see what really happened here up in the North End. So here you're looking at the 2005 numbers and the 2020 numbers. And did you forego any care that you thought you needed for medical care? And you can see there's about a 4% difference there in between 2020 and 2015. So we had on dental care, and so we saw basically people were getting care. Now that could well be it was driven by COVID, because people thought they needed testing or did need testing. People wanted to find out if they had been exposed. So we did see utilization spike in some areas. We saw a lot of utilization go down too, but there was a lot of testing going on at the same time. Dental care, a lot of people postponed dental care this year. So it's a sort of reverse of what we looked at in medical care. In 2015, it was 28%. In 2020, we had 32% of the folks delaying dental care that they thought they needed. Mental health, people didn't delay it. Drugs, just the opposite. We're delaying it even less than they were in 2015. Next slide, please. So here's this questions we looked at. Did you need medical care that you did not get or delayed getting it? Again, this is the 28% said yes. The next slide. And your reasons for not getting or delaying care? Look at that. Didn't think it was serious enough. As a survey researcher, sometimes you want to say to people, and don't repeat this to the people who respond to us, please read the question, because it said care that you thought you needed, but half of them say, I didn't think it was serious enough. Now, we know what they mean by that because we all say the same thing when we respond to these things. But look at this COVID number, just as big. 40% delayed getting medical care because of COVID. 23% cost too much. We see these sorts of things typically about these levels of delaying care for price, for deductibilities, things like that. So the big thing here was the COVID experience really popped out. Next slide, please. Here's the dental care. Let's look at that. Next slide, please. Here we go. The biggest thing was COVID. Didn't go to the dentist. I thought I needed care. I didn't go because of COVID. Next biggest reason I didn't go was because of the cost and my insurance didn't cover it, or I didn't have insurance. And these are the same things we find year after year. The rest of this looks pretty similar, but COVID really was an effect on utilization for dentistry. Next slide. What about mental health? Did you have times that you did not go or delayed for care that you thought you needed? 17%, 16.5% say yes. I didn't think it was serious enough. Okay, we get that, especially you get this answer with mental health a lot of times. People can't decide if they really should go see somebody or not see somebody, and you'll see that in the next two. They're also embarrassed to go. They're nervous to go, as Ann mentioned earlier. We see this all the time for mental health care. And usually we see quite high numbers here. But look at COVID, 24% thought they needed a mental health care and they didn't go because of COVID. That's a big jump. Next slide, please. Prescription medications, okay. Had an RX and had it filled, 64% of people, 30% don't have any. So next slide. Here we go here. Cost too much is the reason I didn't fill it. Again, that's usually the number one reason we see year after year for people not filling prescriptions. Insurance didn't cover it. Those two really go together. Didn't like side effects, always a big issue across time. COVID is way down the list this time. So COVID was an effect for medical care. It was an effect for dental care, a big effect for dental care, and less of an effect for drugs. Next slide, please. Okay, here's a series of questions that got added, and I give the data team a lot of credit for really pushing hard to get these in. And when I say pushing hard to get them in, don't forget a lot of what we do in the Bridge to Health since the beginning. There's a lot of standard questions that you almost have to ask because the rest of the country asks them too. The national surveys ask them, the state surveys ask them, and it's how we trend things going over time. There's oftentimes not a lot of room, and there's always a lot of new questions people want to get in. And people pushed really hard for some of these, and this is a section they pushed hard for in what we call limited real estate in the survey, because you can't send people 50-page surveys. But let's look at these. Next slide, please. Have you experienced any losses related to the COVID-19 pandemic? A third of the people said none. 45% said social connectedness or about the same, say, recreation or entertainment was suffered. Exercise opportunities, social support. And then we see income, jobs. Then we see regular school, sense of wellness, right on down the line. Again, a lot of things going on here. So if we can look at the next slide. We did our magic statistics again. And if anybody wants to know how to do this, it's legitimate. We'll show you how we clump them together. But it makes a little more sense too, instead of looking at all those individual items of how these things clump together. So people responded to these. If they responded to one, they tended to respond to others in the cluster. So again, a third said none. Social connectedness, social support, a sense of wellness, and exercise. 60% of the people fell into that category. Another 25% fell into the job, income, or health insurance loss. And typically those come together. You lose your job, you lose your health insurance. Childcare, regular school routine was another 15%. And then it moved on down from there. Now, let's look at the next slide here. Here it is. We broke it up by males and females. Males said they had fewer losses than women did. Women had more losses of social support by almost 10% compared to the men. And job income loss was about the same for men and women. Childcare and regular school routine was the women carried the burden on that one. Let's go to the next slide. Oops. Who's still on gender? Here we go. By poverty status. Thank you.
Sorry.
That's okay. I keep seeing blue and white or blue and red. So here again, when we look at it, the blue are people under 200% of poverty, the red are above. And we see that the people above the poverty line saw the loss they experienced was social connectedness and social support. The loss that and their childcare and regular school routines were the two where they were higher. In the other ones, it was basically the 200% or less of the FPL that had the higher numbers. And if you look at that housing and transportation number down there, basically nobody over the 200% of the FPL said that was a major loss due to the COVID. But we found a bigger, not a huge proportion, but a much bigger proportion of the folks under 200%. And the same thing with death of a family member. And we saw that, I think, when we heard the death statistics come through, and we know which communities were more affected by mortality than others. And those below 200% of poverty were much more affected by mortality due to COVID. Job loss and health insurance, again, they carried the burden on that one. Next slide, please. That is the bridge to health from 20,000, 20, whatever it is. What year are we in? 2020, thank you, 2020. It's been a long afternoon already, from 2020. And we're going to take questions, but let me encourage all of you. You can get the data, you can get the data book. Know that we're going to talk about that later. I know this is probably Ann and my last year doing this survey. You'll have new folks next time. We've really enjoyed it. And again, what I really enjoyed more than collecting the data is watching what you did with the data. So keep up the good work. And do we have questions?
Yes, there are a couple more questions here. Linnea asks, is there guidance or recommendations about how to consider responses due to COVID constraints or impacts at the research level broadly? So it's hard to know what to say what was COVID or not COVID on an individual question level.
There are some advanced statistical techniques that we can use to try to tease out the effect, where we ask a number of questions, like on the housing barriers or what you lost during COVID and some of those things where we asked the COVID experience or did you seek medical care? We can tease out some of those effects. The other way to do it is look at what happened before, what's happening now, what the trend was, and where we moved.
Mhm.
There's problems with all of these things. The statistical methods are probably the best. When you start to trend, you have to sort of pretend that the trend was going to continue, and you look at the deviation from the trend, and you attribute that to this unique thing that happened. So we have unique cause and common cause we talk about a lot of times when we're doing that sort of work. And what you're going to say is, well, my best guess is everything was unique cause. And last year, I think that's not a bad bet. I'm sure there were some common causes that kept on going that made the trend maybe move faster, but you had a good line for most of those trends. So there are some techniques to use.
Another question, this one is from Cassie. Given that only one adult per household filled out the survey, were the questions phrased, did you or anyone in your household, ...
No, that's not how we ask these questions. We're really trying to get answers from people at an individual level, especially things like smoking and weight status. Those are really individual type measures. So no, generally not. They're not household level variables. They are individual level questions.
Thank you. Another question from Cassie. When you asked people about their income, was the question about their current income? And if so, was it during the time period that the $600 of supplemental unemployment was being offered?
We asked them about current income, but I don't know when I suspect at the time we were in the field, the supplemental unemployment was in effect at that point in time.
We actually asked them about their income in 2019.
Was it 2019?
Yeah.
Okay, sorry.
Yep, total income from all earners and all sources in 2019. And I'd like to go back to the previous question just for a moment and add a little bit more. We are able to conclude that these data represent individuals because of the way we weight the data. It is correct that we draw the sample of households and we asked for one adult per household to fill out the survey, but that's exactly why we ask how many adults are in the household. That's part of our calculation of the probability of selection. And it makes these data represent individuals, not households. So I wanted to make sure I added that clarification for the question.
But it's weighted to all individuals in the population.
That's right.
Yep.
But that's a good question though, because I did talk
That's
about
a really good question.
Mhm.
And, you know, a lot of times one of the things you worry about doing surveys is that people don't think just of themselves and they think of their situation, which involves some of their family members at the same time. So that's why we're pretty persnickety about how we ask the questions, that we use the same questions time over time so that we can really track trends. And in data like this, the trend is the key. The individual data points can move around over time, but that trend is really what you get value from.
and that's
One
why
more
we made such, Go ahead.
I'm sorry, go ahead, Ann.
And that's why we made such use in the presentation. And I do encourage everyone to really look at those wonderful figures in the data book that show the trend over time and pay attention to what the trend was doing in the first 4 Bridge to Health and see then what is happening between 2015 and 2020 and look at the context there. You can see that a lot of times like, oh, this was already happening in some of the results that we showed you here. And then a couple of times like, oh, this was not happening. So something is different now. Go ahead.
Great, and we have
Sarah.
one more question in this section, and it kind of relates to that. So when reviewing the data, did you see any trends regarding mental health status and reporting on prevention, food security, physical activity, etc.? I noticed reporting on education and poverty, but not mental health status. And do we need some clarification on that?
Yeah, can you read the question again,
Okay.
please?
Yes, or maybe I can see if Julie wants to clarify that. Julie, I will try to unmute you here.
I'm wondering if Julie's looking for a crosstab on mental health status and some of the other variables that were measured. But if Julie's able to ask, that would be great to hear from her.
All right, Julie, you can go ahead and unmute yourself and ask that question.
Yes, Mary is absolutely correct. I am looking for the cross tabulation on mental health status. I'm just wondering if there's patterns of loneliness and social isolation, and then how might the data reflect someone taking action on other health measures, if there were anything from the data that we could gather on that information.
There's definitely possibilities to look at these things. We were constrained by the amount of time we had here. And
Absolutely, yep.
But yeah, I am sure there are fascinating differences that you can find. And you can start by looking in the data book, but also there could be possibilities to get your own data set. I'm stealing someone's thunder here, but to do your own analysis or even contact someone on the team to help out. So there's definitely going to be some interesting things for you to see.
And you do have some variables in here that you can use. There are some ways to use the variables you have and create an index of mental health status. It's not simple, but you could. You can cross tab, of course, by people who have had a chronic mental illness and been told they have one. You can do it by their current depression or anxiety. But a lot of that anxiety and depression, when you start to get into the details of it, is transient. And so depression can be a chronic condition, it can be an acute condition, it can be situational. So you've got to think very carefully about what you mean by mental health status and the context in which you're going to use it, because you can cross-tab by these things. My sense is you're probably looking for more of an index of someone who has. It's interesting to look at transient states and see what's happening at a given point in time. It's also interesting in looking at people who have ongoing mental health problems.
Yep. Thank you.
Okay. Thank you very much. That's very helpful.
Thank you.
Is that it? I'm going to pass it on if that's the end of the questions to Sonia.
Oh, there was one other one.
What, did we miss one?
There was one from our dear friend, Pat. I wonder if we can unmute Pat, because I'd like her to talk about it. That's Pat McCone.
Yes, I will. Okay, Pat, I think
All
you
right.
can unmute yourself.
We can hear you, Pat.
There you are.
Thanks. The great data, but I did also want to note that this was the first year, probably some of the first data gathered by a large population of the impact of age, changing the age of purchase tobacco from 18 to 21. It happened in December of 2019. It didn't go into effect until January. And so this data would have fallen right in that time when it was more widely known, because it happened very quickly at a federal level.
Oh, Pat, thank you very much for that context. That really, I'm very sorry that we didn't talk to you before the presentation, because that could have lent a lot to the findings that we were talking about, comparing that to 2015. Thank you so much for bringing that up.
Yep. And I will say, this will also probably will be my last survey. And I have really, it's been a highlight for so many reasons and been so valuable in the learning process and really being strategic in how we think about the changes in the systemic bias and the way our communities are laid out, and we can more carefully and thoughtfully plan for health in all policies and health in all communities. So thank you guys. It'll be fondly remembered in the archives of my limited capacity brain. So.
Oh, thank you so much, Pat, for all your help over the years and all your participation and great ideas.
Absolutely. And other questions, is that it?
I believe
All
so.
right, you're on to Sonia.
All right, well, thank you, Mike. And Mike, you did a wonderful job of walking us through the survey methodology and providing some really exciting highlights of the results. It was, really gratifying for me to take it in as we are now entering the 16-month mark of this project. So really fun to see the results of all those efforts. So good afternoon, everyone. If what Mike and Ann presented piqued your interest at all and you want to learn more, I am here to show you the way. So most things related to the Bridge to Health survey can be found on our website, bridgetohealthsurvey.org. Lots of great information here. You can learn about the history and the purpose of the survey over the years, meet our great community partners, which make it possible for all of this to happen. Learn how to contact us if you need more information, if you have questions. And of course, this is where you can find the reports. So the regional, county, and city reports for all 6 Bridge to Health survey results can be found posted on the website. And if we take a look at the 2020 set, you can see now that the regional report is available. You are welcome to come online and review it here, or feel free to just download a copy for yourself. And we also, I think, had some questions about the conference slides and some other resources, and those will be available on the conference tab as well. You can find all the materials from this conference available there as well. So something new for the 2020 survey are the data dashboards. So the intent of the dashboards is to take a deeper dive into the survey data from the perspective of a specific focused topic area. And our plan is to fill out this page with additional dashboards. And I welcome suggestions on topic areas. Definitely we'll put one together for mental health. We have a lot of interesting data from the survey, and certainly a lot of interest among our community partners and organizations for this. So that will be coming. But if you do have other ideas for topics for the dashboards, please send them my way, because we really would like to post some additional information here. So let's just take a quick look at the dashboard that is available currently. The focus is on weight status. So this dashboard is also available through Tableau Public. And if you would like to take a look at the dashboard on that platform or check out some of their multitude of interesting dashboards, you can go ahead and click on their logo down in the left-hand corner. If you're not familiar with Tableau, I just want to draw your attention, got to move my screen here a little bit, to this lower right-hand corner. There's some very useful function icons. For example, if you want to share the link to this dashboard, or you want to embed this dashboard on your own website, you can do that from this share window. Or if you are interested in the page view for a particular page on this dashboard, or for the entire dashboard, the download window gives you some options for downloading those page views. So the weight status dashboard is comprised of 5 different pages full of information drawn from the 2020 survey. And just navigate to those pages by either clicking on the blue boxes in the navigation bar at the top or the arrows on the end. And again, most of the data is drawn, or almost all of the data is drawn from the 2020 survey. The one exception is this lower left-hand corner. We have a line graph of data from previous years. We've collected weight status data in every survey. So for all 6 of the Bridge to Health surveys, you can find the results for that weight status. And again, keeping in mind that we had this big methodology change in 2015. So 2015 now becomes the baseline for future comparisons. So specific to the weight status dashboard, this is tips sheet. So to take advantage of all the features specific to the weight status dashboard, you can open up this tip sheet, and it just gives you some tips, some hints about the functionality of the dashboard. On each of the pages, there's a filter that gives you the option to select a subset of data to be displayed. So for example, on this age group chart, you have the option of choosing both sexes, or you can filter by a single sex, and that'll change the data that is displayed. So one purpose of the dashboards is to provide information that's not available in the published reports. An example here is a crosstab of weight status by chronic medical condition. One feature in the dashboard that I find particularly helpful is the information box that pops up when you hover over any of the individual chart elements. So what you'll find in those pop-up boxes are details about that particular element, but also what's really useful is how to interpret that element. So sometimes when you're looking at these charts, especially this one, it's tough to decide, should I read this vertically or should I read this horizontally? Well, if you look at the interpretation statement in this pop-up box, that takes away all that confusion. So hopefully you'll find that helpful as well. On four of the pages, there is a filter to select the survey sample area. So the default display is for the entire regional data set. But if you're interested in a specific location, a specific sampling area, let's say Cook County, you can go to this drop-down menu, select Cook County, and all of the charts on that page will now display the data specific to Cook County. And this filter is just specific to a single page, so it doesn't carry over from page to page. And to clear that filter, you can go back up to the drop-down menu. You can select all, or click on the filter icon on the top, and it'll revert back to displaying the data for the entire regional data set. We try to provide some handy definitions for the chart elements and categories. They're either in text with some helpful links to the source of the category definition, or for example, on the lifestyle page, you can click the lifestyle button. That'll open up a page that gives you the specific definition of each of those categories, so you know exactly what the charts are referring to. And that will wrap up this quick tour of the weight status dashboard. And I invite all of you to come back and visit the website and explore this dashboard and the dashboards that we plan to have coming soon at your own pace, and really get some use out of the extra data that's being provided outside of the published reports. And again, if you have any ideas for some additional dashboards, please pass them on to me. So for those of you that are researchers or other people that are interested in custom analysis, I'm going to stop sharing my screen here, that are interested in a custom analyses of the data, we have a public use data set that's available with accompanying data dictionary and survey map. And you can contact me directly or anybody at Generations, and we'll be happy to get those files to you so you can do your own research. I do also want to mention about, we have the regional report that's available for the 2020 survey. The city and county, creation of the city and county reports is underway, and we anticipate posting them to the website by mid-June. We'll send out an email with an announcement when they are available, so keep an eye on your inbox over the coming weeks for that. And finally, I just want to close out my little segment here by encouraging you to let us know how you use the Bridge to Health survey data. We're really interested in any application, whether it's a research project, whether it's a community health needs assessment, grant application, program development or evaluation, whatever it is, please pass along those stories to us. This type of feedback is really helpful for us as we go forward and determine whether or not we want to keep up the Bridge to Health survey tradition. So we love to hear from you. And with that, I will say thank you and pass it on to Mary.
Wow. Thank you, Sonia. That's the first peek I had at the data visualization, and wow, you did an amazing job. I'm just so excited about the opportunity to look at this data in a more interactive form, and I think it's going to be an incredible resource to the community. So really appreciate the work that you put into that. I'm going to make a few final remarks, and then I think we may even have 5 minutes for additional questions. And I think actually Ann and Mike agreed to stick around even longer to chat if people had questions after our 3 o'clock closing time. So first of all, thank you all for attending. We will be sending out an email to all attendees with information about CEUs. We did get approval for 2 CEU credits for the conference, for participating in the conference, and a special thank you to Essentia Health for helping make that possible. We will also include an evaluation. So we do appreciate any feedback that you have for us. Notes on how we can improve are always so helpful in planning for future events. And as Sonia mentioned, be watching for a notification. We have our regular communication vehicle, and we'll make sure that those that registered for the conference are on our mailing list so that we can let you know when those county and community reports are ready and available. And then finally, I do want to just give a special thank you to the Bridge to Health 2020 co-chair, Maggie Rothstein. Thank you, Maggie, for being my co-pilot on this journey. Dana Kazel from St. Louis County was the co-chair of the communications team. Generation staff have been amazing throughout this whole process. This is one of those projects where it's all hands on deck. Whether you're leading a team or behind the scenes, everybody on the staff played a role. So, special thank you to Sonia, our information manager. You can see the amazing work she does when you look at that data book and the Tableau dashboard. Megan Helena, wow, sensational job co-leading our communications team. Thank you, Megan. Brenda Elinardo, our administrative assistant, doing all kinds of great things behind the scene. Terry Leonidas, our CFO, and of course, Sarah Nelson, who was helping today with meeting logistics. Thank you all so very much. And of course, last but not least, this is where I start to tear up because Mike and Ann alluded to this. This is likely their last Bridge to Health survey. And we're just so grateful for the 25 years you put into this with your expertise and your knowledge about the process, your love of the process. It has been just an absolute joy to work with both of you. And you really have sort of left a legacy in our region with the work that you've done with the Bridge to Health survey. So I wish we were all in a room together and we could applaud you, because I'm pretty darn sure there'd be a standing ovation at this time. So again, I will sort of close our official time together, but we're willing to hang out and even unmute people. I bet there's folks, Jenny Peterson, who probably want to get off mute and want to say a word to Mike and Ann, or if there are any other questions. So Sarah, did you see?
Before we go there, I'd like to make a few remarks. While Sonia was talking, I was taking a little look at the attendee list and seeing a lot of good old friends and wonderful colleagues from over the years, good friends to this project and good friends to me. I am retiring. Oh no, there I go. and I will miss all of you. So thank you very much for bringing such joy to me during this project. Mike, you're on mute.
I got to push 2 buttons, and I'll second everything Ann said. Good friends, good times, good memories too. So thank you all very much.